Hello, everyone, and welcome to another edition of Health Blue Squad or the Blue Squad on Health. So, today I am joined by Dr. Donney John of Virginia, USA, and my co founder, Shahzad Hashim, who is the brain behind most of our products. So the last week has been quite exciting again, and Trump makes sure that we are all excited about everything. Today morning's news was about the cancellation of $800 million of grants for Johns Hopkins, which is going to impact many of their programs. They work closely with USAID. So maybe live in interesting times is what they say, and we are going through interesting times. So on today's subject, introducing Dr. Donney John here. It's a mouthful, so I'll call it Donney from now on. All right.
That's fine.
Right. Donney and we go way back. I met him as an avid patient advocate, and he is running Novascript Central, and he's a major player in the nonprofit sector. Novascript Central provides medication access and assistance to families in need and people in need. He's also involved in a lot of nonprofits. So I'm going to let you introduce yourself a little bit, Donnie, because you have been doing quite a lot of things that I am not aware of. So here's to you.
Well, thank you for having me, Shaheem, and good morning, everyone, or good afternoon, depending on where you are in the time zone. But as Shaheem mentioned, my name is Donney John. I run a nonprofit called Novascript Central. We provide life-saving medicine and health services to the uninsured that live here in Northern Virginia. But I serve on a lot of boards across the country focused on health disparities, helping people gain access to care and eliminating barriers that will improve health outcomes. So I'm excited to talk about value-based care and patient engagement today with all of you.
Right, Shahzad.
Yes, sir.
You can give us your new 2 cents and just introduce yourself, and then we'll go from there.
Yeah. So in the healthcare space for almost 15 years, although I don't look that old, very closely working towards seeing how technology can enable uh, delivery models like what Dr. John is trying to do, and give accessibility to patients, give tools that help doctors deliver care without the burnout. So that's what we are into, and very passionate about that.
So now that everybody knows everyone, usually the show, I have two of my old friends. We call ourselves the bandicoots because we have all been in the industry for quite a long time. And we just like to sit and, talk about like the old man's get off my lawn kind of a thing, things that is going wrong in digital health, all this kind of things. But today, um, they aren't here, but we will still have a very lively conversation going. So, as you know, Donnie, we are very much in value based care, right? And as things go along, value based care talks about patient outcomes and the quality of outcomes more. And the importance of that patient engagement, I want to discuss whether it is being really felt by the patients. Whenever I see solutions going out, I see digital health applications. Whenever people talk about patient engagement, it's like, oh, we have an app. We have an app which helps the engagement. I'm trying to understand what exactly people say when they talk about patient engagement. But I think you can start with your philosophy on patient advocacy. Why did you start doing that? And I think it's a very close relationship with patient engagement. It is basically patient advocacy in another form, right?
Yep.
So I would like to hear your views on that.
Sure. So I started my career in academia, and my focus as a college professor was health literacy and cultural competency. When you join a faculty of a university, you have to choose an area of expertise as a healthcare professional. And I chose health literacy and cultural competence because what good was it to be brilliant about a disease or a specific area if your patient didn't understand what it was? So for me, serving and working with very culturally diverse communities that are coming from all over the world with different socioeconomic statuses, it was important for them to feel empowered, give them the tools to help them understand their illness so that they can better manage their health outcomes. So health literacy is one of the most important things that we take for granted. We expect everybody to understand all this information, and regardless of education levels, it impacts people that are well educated and people that don't have high school education. So it's something that's a universal factor that we have to really put thought into and think of how do we creatively engage people. And one thing I learned over the years is that as much as we try to focus on improving literacy from a health standpoint, we also have to understand the fact that just translating educational content into the patient's native language isn't enough, because a lot of patients can't read in their native language. So a lot of my work has always been, how do you use pictures and visuals? How do you engage them? How do you spark an emotion? Where I like to always joke around saying the person should walk away feeling like they spoke to a crazy person, because I want them to remember that experience, because when they go home, the goal is to share the content with their friends and family. And I use smoking cessation as a perfect example. If you have a person that needs to quit smoking, if they are amongst other smokers, and if they're not going to quit, but if they feel supported, where they have a support system that people will say, "Oh, that seems reasonable. You can do it. We'll be with you on this journey," then they're more likely to succeed. Health literacy is the same concept for all diseases. It's really helping that individual understand their illness, share that information with their loved ones, so they have somebody that can kind of back them up. Because a lot of times in most communities, patients go to the doctor's office, they smile and nod, and then they come home confused. They don't know what's going on. And we talk about patient engagement. We're not really designing it in a way that makes people want to understand. It's more of check the box or click the box on the computer screen because it's part of a metric. There's some reimbursement, but that reimbursement is kind of short-lived. It doesn't look at the lifelong journey of that individual who has an illness. I often say a lifetime illness takes a lifetime of healing. It's not within a 45-minute visit, a 1-hour visit, or 6 months that you're going to get diabetes reversed or cardiovascular disease reversed. It's about helping that person understand how to change their lifestyle for their whole lifespan and really changing habits. But we need to have time. Luxury of time is what's missing. And you pointed out to digital health apps. I equate a lot of these apps to fitness apps. Jan 1, everybody's on the fitness apps. A month later, everybody's done with it. And that's kind of where technology is right now in healthcare. There's something new, someone raising millions of dollars in seed round funding, but it's a fool's errand, because they're not thinking about longevity. They're not thinking about who needs the solution versus kind of, it's a nice to have, but not a necessity.
So what I'm thinking is you covered a lot of points out here, right? It was a little bit too much to grasp on in one answer right there. You're talking about health literacy, support systems, all these areas. There's much more than what we're talking about. And another thing was you covered on the area of companies starting up and raising seed rounds on this thing. And one of the topics we covered in the past was, is their over investment in digital health, right? Anybody who comes up with an idea and then they are drowned in capital and then you don't hear about them. There are so many companies. So one of the things that I'm thinking about is every time you see there is this company raising that much money, there's another company raising that much money, but very few have actually made impacts. And I don't see any of those sort of things out there. And Shahzad, this goes to another company that we were proposing to work with, right? That was the University of England or SOS, I think.
Yeah.
That's what we are talking about. I'm alluding to the fact about behavioral change, right? So can
I think,
you?
yeah, from one thing from what John or Donney was talking about, right? I think he's been working in a space where he's providing needed medications to uninsured and people who can afford them for, I think, for the last 15 to 20 years, right? I see that value-based care has picked up as a key term in the last 5 years with, the government pushing it, etc. But value-based care has been always there. For example, you are actually trying to deliver value-based care in another format, fundamentally to help the patient. How do you see with what is moving and happening on value-based care? Because right now the conversation is all around, you mentioned check boxes, because it's all check boxes to money to kind of show that you did the thing, right? Because when I was working with one of our clients who's into community health, the therapists have a reality on the ground with the community, and they have a reality on the ground with what they should report. So they show that they did their job. And doing the job and getting the patient well doesn't necessarily always come together, right? So how do you see that? Because I think the core of value-based care is providing value to the patient, to improving their illness and to making them part of the community, or being, be able to contribute to the community. So talking from behavioral perspective. So how do you see the shift, and how do you see that, how do you see it ingraining into making sure that the patients get the value out of value-based care from the model?
It's a great question, and I came to Virginia, over 10 years ago to really focus on the Affordable Care Act, helping health systems implement the Affordable Care Act and putting quality improvement programs across the country. And before that, I was in a clinical role working with patients directly, and then moving into the business side of it, helping to implement the Affordable Care Act. I saw firsthand of what you said, the clinician and the boots on the ground experience versus the business side experience, where people like to sell something, but the people that deliver it don't know what is it that they're supposed to be doing, and the confusion because no one knows the challenges to kind of get that message across. The biggest challenge is that no one asks the people that have to do the work, what tools do you need? How do I make your life easier? It's always an assumption. They read about it in a book. A lot of times when I would talk to people about, can we get educational content translated, or can we make this a different widget, or this, a different part of the workflow? It's always, that's on the product roadmap. That'll be, next quarter. We're flying the plane as we build it. I'm like, I don't need analogies. These people that are suffering from illness can't wait for us to have another quarter to keep building a plane and having all these buzzwords. We really need to think about human-centric design. And what I always advocate for is, think of you as a chief patient advocate for you and your loved ones. How do you remove the barriers that will enable your loved ones to access care? Because at some point, we're all patients. We're all going to have to be a caregiver. And the frustration that we face when we go to the hospital or a doctor's office or dealing with insurance companies should influence how we make life a lot easier. So when you want to create value, it's really understanding what is the value that you need out of the user experience, and not just assuming other people's experiences. Because some people might say, oh, I'm completely healthy, I've never had to use healthcare. Well, you need to go and look and find people that have the lived experiences and leverage their knowledge to know if they're caring for somebody with cancer. What is that cancer patient's journey? When we talk about financial toxicity, these are all factors that deter people from going to the doctor's office. How do they pay their copays? How do they get to the doctor's offices? And then when no one answers their questions, that's a big part of the challenges. People not answering questions in a way that everybody understands. And I think from an employer standpoint, it's getting everybody on your team to understand the why. We're just telling them the what. I need you to do this. This is going to help us for this new metric, and we need to use this ICD-10 code for this purpose. But if you don't understand the why, people are not going to confidently do the work. You're just adding layers of complexity to their already hectic schedules, and then they can't execute. So, to answer your question, the value to generate value, you really need to understand from you as an advocate experiencing healthcare. How do you want your experience to be better? And all of our experiences vary based on region and where we live and what we have access to.
So how does advocacy work, Donney? When you say you're a patient advocate, what is it that essentially you do?
So in essence, for advocacy, it's kind of depending on the situation that you're going into. You're trying to figure out, how do I help improve access to food or healthcare, or getting patients to a doctor's office, right? One of the things we do at Novascript is we work with a lot of refugees coming to the U.S. So we start educating them how to navigate the healthcare system. How do you prepare for a doctor's appointment? Something simple as that, where a lot of people don't know, they've never had healthcare before. They're walking into the U.S. experience and they don't know what they should do when they go to the doctor's office. Are they allowed to ask questions? What type of questions are appropriate? What's the follow-up look like? So you really look at, you're advocating based on what that experience that the individual is about to have, whether it's going into the hospital for a procedure, explaining what are your rights, knowing, post-op care, the discharge planning, what do you need when you get home? Because everybody wants to do surgery, but then what about the planning afterwards? If you're out of work, do you have support systems that can help you offset lost wages? So advocacy is, really depending on, are you focusing on advocating for food access, make sure people have a meal to eat? Are you looking at transportation so people have an opportunity to get to their doctor's appointments or get to work? Are you looking at housing based on people that are experiencing chronic homelessness, where they need housing in order to figure out to manage the rest of their life? Where right now the buzzword is SDOH, social determinants of health. So advocacy is really dependent on each one of those things, and how we can kind of connect it where it's not one or the other, it's all of the above that we have to address.
So you say that's what, when you were saying that it all checks the boxes for patient navigation, right? Patient navigation is one of the key ingredients of value-based care when it comes to patient engagement aspects of it. And you talked about people, you working with refugees, but actually most of the people, citizens like us in the United States, would like that service, because even we don't know where to go at some times. Where can we get certain services? What can we do? What are our rights, right? We are getting into this area where we feel really lost. And many successful, and I have been reading articles and case studies about this, is many successful organizations or hospital groups or health systems, as you may, they are employing this as a key ingredient of patient engagement. So going back to my initial statement where I was talking about the idea that a single digital app is what patient engagement is all about, is entrenched in many or a good portion of the public, as well as a good portion of the digital health entrepreneurs. They come in and they think about that. But our philosophy is that it encompasses a spectrum of services, including patient navigation, right? Where you can get all these services where you call a system and they will help you, they'll guide you, including triaging and post-operative care or care coordination, all these kind of things. So that's really interesting that so far, because those systems ignored these aspects, people like you were required in the system to provide these services and call it patient advocacy, right? And now in value-based care, it is being for the effective implementation of value-based care, not the checkboxes like you mentioned earlier. These systems have to be folded back into the health system that needs to be doing these kind of things, right? So what are your thoughts on that?
Yeah, I was just thinking, because I think 15, 20 years back, the model that Dr. John was, there are clinics who actually give or introduce them to patients who need medications or who need education, things like that. I think that was the model before. You have partner organizations who see a patient who might be eligible for your services. They send you, then your nurse or your administrative staff then look at eligibility or try to see how they can help them out. I see a lot of variations of this process right now. What you're doing it as non-profit at that point of time, right? And now we're seeing a lot of organizations who are coming in as value-based enablers, for a lack of another word. And they're trying to implement this so that if there is a physician group or a physician office who doesn't do parts of the value-based care spectrum, like at-home visits or remote patient monitoring, or after the hospital, take care of it, and then bring back HCN numbers, coding, etc. I see a lot of consulting. I see a lot of providers. How do you see that space has grown, and how do you fit as a non-profit in the medication space, and how does it fit all in together? Do you come in the value-based spectrum? How do you see that movement of communication between different doctors' offices?
Yeah, no, it's a great question. There's a lot of profitability in the chaos, right? So you have a lot of money that's being made based on the dysfunction and just kind of creating quote unquote efficient processes, and a lot of pretty slide decks that help people get the message across. But when it comes to execution, it's really understanding what does the patient need? Are we listening and asking and designing with them in mind? A lot, as I keep referencing, most of the decisions for patient engagement are made without patients. They're not at the table when it comes to the design. The people designing haven't used healthcare as critically as some of these patients that have congestive heart failure or diabetes or mental health. So knowing what the patient needs is kind of the most important thing of having them as part of that design to really make the workflow work. For nonprofits like ours, the need is always going to be there. We're not going to end poverty. That is a false idea thing that we're going to work ourselves into a job. It's the goal should be, how do we elevate people from being in a unfavorable situation to a better favorable situation, so we could go back and help more people, because that's what we're not willing to do. We like to kind of keep everybody at the status quo. And from an insurance standpoint, because most insurance in the US is you sign up for 1 year, whether it's through your employer, through the Affordable Care Act, for Medicaid, Medicare, you have that 1 year time frame. So when I've talked to insurance companies and asked, well, why not do this, in order to be proactive for preventative care and helping the patient out? Well, if I make this person healthy for in this 1 year, they're going to go to the other insurer next year. So why should I make them, healthier for someone else? And it's kind of like, well, the whole point of insurance is to help reduce costs and help keep people healthy. But, the reality is, health insurance, car insurance, whatever insurance you have, it's about never having to use it, because the companies will make money because they have the insurance premiums and you've never touched it. But the minute you need it, then, everything goes up in price. And it's kind of counterintuitive, where if you want value-based care, you have to make that investment in preventative care. How do you focusing on the food access, health, fitness, all those things, where some of those things are personal attributes that you don't have control over as a clinician or as a provider. I can't go tell someone to go physically to the gym and see a result in their exercise routine. I can recommend it and strongly encourage it, but there has to be a willingness on the individual member to really get engaged. So patient engagement comes from understanding and leading with empathy. The groups across the country that do it well, they do it from a culturally competent approach, where they understand the cultural, they understand the barriers, they understand the social norms for a specific group of people, and then they design plans, programs that engage them respectfully. And having a diverse workforce is crucial to making that successful. You can't read about it. You can't use AI to think about it. I'm going to fake it till I make it. Having somebody that looks like the person that's being cared for is extremely important, and we undervalue that because we just think, that's just a nice to have. And once again, product roadmap. In the next quarter, we'll do that. Once we get more funding, we'll do that. Where if people are struggling with diabetes, you need to figure their stuff out right now, especially in multiple languages. The language is a huge barrier. We do not focus enough on creating educational content or to help engage patients in a meaningful way. We have a lot of translation services that tend to be expensive. You pay by the minute for a translation service online. When I've been looking at AI solutions to figure out how to do translation for educational documents, and there's a word count. I'm like, I'm a nonprofit. I don't have a big budget. So if you give me a word count, how am I supposed to work with that versus me finding a staff member that speaks the language that is more cost effective for me long term? Because now I can send the staff member out in the community to engage versus AI. Where am I sending that out to? Am I just throwing out an iPad and expecting someone to react with the iPad, or sending a human being that's going to have empathy and really focus on engagement?
So am I hearing you saying that, let me backtrack. I'll post a question after my statement, right? So the other day, I reside in Switzerland, right? So many of the correspondence is coming to me in French. So we got this lease offer from Audi. And so it is all in freaking French. And I'm a novice to French, so I cannot read all these things. And there's all the features listed out there. So I got 2 quotes, and I'm trying to compare which one is better. So I have subscription to OpenAI and the deep research or whatever. So I fed these 2 in it, and I asked it to analyze and give it back to me. The documents were in French. It analyzed it substantially and gave me a clear conclusion. It gave me what is the variance and all, which I would have, even in English, I would have had to sit down and do all this work. So the point is, what you say would have been correct about a year and a half ago. No, I'm not using the word correct. I mean, would have been valid probably 2.5 years ago. But now AI has come to such a level. A translation is one of the easiest things that can be done. That is number one. The other thing, there was another area where you were talking about is in terms of technology that can be solved by that. But what I'm hearing, and here is the question, is that technology, how much ever advanced it gets, is not enough. An empathizing human being is necessary. Is that what I'm hearing you say to have an
Yes.
effective? Uh, yes, that is
Yeah,
what.
100%. You can have tools. I think
So,
AI and technology is important tools to assist you in doing the great work. You definitely need to know, which tool to use in what scenario. So if you have a toolbox, which screwdriver, Phillips head or flathead, am I going to use to put together something, right? So knowing and training people to understand, especially clinicians and healthcare professionals, what's the right tool to use in the right situation. A lot of times they're given tools that are not appropriate. So helping them understand, here are your options. Here's a tool to use in this scenario versus that other scenario, and make it efficient. Because I definitely think technology has a huge part to play with it, but it's just really getting the clinicians and the healthcare professionals to be comfortable knowing what are its limitations and what to use. Where a lot of times clinicians just look at the computer screen; they don't even look at the patient anymore. So
right.
having that perspective of just looking at your patient and having a conversation with them, where the fact that there are a lot of the scribe software where it allows you to speak to the patient, and then the computer software will record everything and put the note in the EMR. Those are great tools because that's allowing human connection. So I think the tools are going to be important that facilitate human connection better.
So here is my follow-up question to that, right? One of the biggest problems that we are going to face and we're already facing is a lack of clinicians per thousand of population, right? Per quantity of population, and it is especially dire in developing countries, right, where there is not enough qualified clinicians, especially in rural areas. And one of the ways that we seem to be having hope is the rise of artificial intelligence and intelligent tools. So how can we, or what do you have a vision on that as to how can we merge this empathy with that automated workflow? So for instance, our company has developed an AI agent that can help in navigation services, starting with appointment setting and then going and finding an alternative doctor, including a little bit of triage, putting them into the right direction. So like you said, AI agents never sleep. They are never fatigued. They are never impolite. We plan them in that way. It helps a lot of people. It also uh, dissuades people from having any sort of inhibitions when they think that they're talking to a machine. They can talk more honestly uh, about their conditions and other things, right? So what I'm seeing is, and many a times, many a times, the AI, artificial intelligence comes across as more empathetic than an actual human being. So, and to me, the biggest problem that we'll be having, especially as the population of the world goes towards the geriatric side, right? Because in the next 20 years, it's going to be a substantial population of the world's population is going to be on the older side. Past 2050, it's actually, people are saying it's going to decline. I mean, not people are saying, studies show that it's going to be declining. And to take care of this large population, delivering a personalized care cannot be an empathetic care. Can it be done without the help of AI and other things? I'm not saying you said that we should do it without the help of AI. I'm saying, is that possible to have a human being deliver that kind of touch points? Shouldn't we reserve those touch points for a place where it is absolutely necessary? That's something,
Yeah.
Shazad,
Well, it's a great question because, as you pointed out, there are a limitation number of resources available. You can't help everybody when there's only a handful of clinicians and institutions that can deliver the care. That's where telehealth and all those opportunities to extend reach comes to play, but it's more of how do you work with the community, the local communities, working with faith-based groups or local people in the community, that you can give these tools so they can help engage, they can facilitate the conversation and be that intermediary between the clinicians and the health systems and the community directly. We often hear a lot about work with trusted messengers, and that's just a buzzword. Very rarely does that happen where you truly work with the trusted messengers in that community, whether it's a community organization like Novascript, a faith-based organization that's out there in the community, to really engage and serve the public. Leveraging existing community infrastructure, where now we have community health workers. That's like the new big thing over the last 2-3 years of of new healthcare titles is community health workers helping with navigation. We'll give them the tools, teach them how to use the tools so they can help extend that small resource pool to a larger audience, right? Because what you don't want is people showing up to a doctor's appointment or a health system, hospital system, without any knowledge, right? They come ill prepared. That creates more complications. The analogy I like to give is kind of, people think, getting to the doctor's office is like climbing a mountain, and it's very treacherous. So if you climb Mount Everest, it is extremely hard. You need to have guides to get you up to the mountain. But what's even more dangerous is the descent, is when you're coming down the mountain. And that's what people have to figure out is, when you go home from a doctor's office appointment or any medical visit, what does that experience look like for the patient, the consumer? How do we support them when they're at home? That means, how is it that they have access to food, shelter, and all the other necessities that will impact their life? They're not direct impacts, but they are tangential things that's part of the SDOH, the social determinants of health, that will really drive outcomes. Because the patient can tell you everything you want to hear during a visit, but the reality is going to be substantially different when they get home. So it's just, to me, that descent, climbing down the mountain of getting to the doctor's office. How do I give them the tools that will keep them empowered, self-sustaining and empowered?
I like that answer in the sense what I'm hearing in layman's terms, which I am, right? It's basically, these tools can help even non-clinicians serve the community, and they can be used with empathy. So you can actually have a merging of the two. So, many of the, I don't know whether this analogy is going to be right, but I'm going to try and say this, right? In the sense, we have these nurse practitioners or other people who are assisting the doctors, but they don't have as much of education or training as the doctors would, but they know just enough to treat the common patients. So if you use these kind of new digital or AI tools, and they are given the support of an AI agent or a clinical agent or something like that, they can do even better. So you can start filtering the patients, which is one of the things that value-based care ought to do, is then the best resources that you have can be reserved for the most critical conditions. You don't have, in other words, you don't have to kill a mosquito with a can, Confucius, right?
And I think, yeah, and I think, especially from a product solutioning perspective, right? When you do look at the drawing board, you always look at how can the product functionality provide direct value. Unfortunately, the direct value comes directly connected to compliance or reporting or things like that, right? Which is where always, for a business owner who's trying to take a solution, be it digital, be it EHR, whatever you want to call it, always the conversation is on how do I get the direct value? How can I increase my billing? How can I make my coding better? Blah, 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 right? I think the real focus from what you've been saying is to be looking at how do I provide the most simplistic tools to help do whatever the care provider and the patient is doing better, which might not really have a direct business value at the upfront level, but it actually goes into the workflow, goes into the ecosystem, and really drives. And I think those functionalities are really not that fancy, right? How can I have 3 communication modalities for the same thing? Language, visual, so that depending on, I'm going into a community, I'm meeting a patient. I can have this in my hand, really flexible, and I can show what works for patient one compared to patient two and make them effective, right?
Yeah,
I don't.
no, 100%. I was recently having a conversation with someone talking about nutrition. When we look at nutrition is the key function for almost every illness, chronic disease, whether it's diabetes or cardiovascular disease. If you don't have a good diet and nutritional habits, your outcomes are not going to be good. But when we look at making dietary recommendations for patients, it's all generic. We don't customize nutrition based on what's the identity of that individual patient. This is really where technology could come in. I would love to see an AI tool that will allow me to say a patient is coming from Uganda, patient is coming from the Middle East, create a cardiovascular friendly diet for them, right? That takes into factors of what are their nutritional needs based on their their ethnicity, right? If you tell someone from the Middle East or from Asia to avoid rice or carbs, that's not a good solution, because they're not going to listen to you. But how do I know what are my alternatives? When we look at vegetables in the Indian diet, vegetables are a huge part of it. But those vegetables don't have necessarily English names that you're going to go find at your regular grocery stores. If you go to the ethnic stores, you might find things that are not available anywhere else. But none of our communication tools or resources take that into factors. But this is where technology can really help create specialized nutrition plans that are based on what people are going to eat. If I don't know what's the cuisine of people in Uganda or from Brazil, at least let the solution help guide me so that I'm not making a recommendation that's unrealistic. And the one thing we do when we teach people, it's always about knowing where they come from, really spending time to understand how food is such a core part of their relationship to their health and each other. So if you're going to expect someone to give up something, what does that mean in terms of their family social structure? Is it realistic? If the husband is the one that's not cooking and the wife is the one that's cooking, do you tell the husband, don't eat this, and he says, well, my wife makes it, what do you want me to do? And vice versa. If the wife is the one that you're talking to, and then how do you help the wife convince the husband and everyone else to follow the dietary recommendations? We do that through a lot of our education programs, where for our diabetes workshops that we do, we influence people, and then they take that lessons learned and they change their families. We had one family lose 110 pounds because the mother came to our workshops. She got her husband to get on board with the dietary recommendations. So the husband lost a significant amount of weight and her son lost a lot of weight. But just that one engagement over a course of 6 months allowed the whole family to lose weight and maintain weight loss. Those are things that don't typically happen because it's just a quick, fad diet perspective, and then we look at, all right, we've hit our metric, so we're going to get paid. But then what happens downstream when they go backwards?
Do you see realistic changes to connect the checkbox and the reality of the patient, changes in policy and things like that? Or do you see a direction in space that you're working?
I think there's possibility. I think that's, given all the chaos that's happening with the funding cuts that are happening across the board, it's, consolidation needs to happen in some capacity. And I often like to say, for my industry that we serve, the uninsured, there are 1,400 clinics across the United States that serve uninsured people. And I always like to say we are incubators of innovation, because we have no money and we have to help the most needy. So we have to get creative, because the lives of 2 million people depend on the work of these 1,400 clinics. Because if we fail, those people fail. So for us, it's always about survival and thinking about how to be innovative, how to be creative, leverage solutions, where you can, in order to have the best possible outcomes with very limited funding pools. So now on a larger scale, instead of kind of doing the continuing things that are siloed, that don't breed efficiency, now with the consolidation, people are going to be forced to collaborate. There's going to be forced collaboration. So if you really care about doing something and making the impact, you have to walk the walk. You have to be willing to put your egos aside and come to a common business interest and think about long term, in a 2-year, 3-year, 5-year plan, what does the business outlook look like, versus just a quarter by quarter perspective of, to what you pointed out, there's no immediate business impact in doing this one activity. But in 2 years from now, that's really where the cost savings and the revenue generation could happen. But we have to build it the right way.
And who funds? Sorry, go ahead, Shahzad. I'm sorry.
No, I was just asking about this. When I was working in the community ed space, I did find it that, the leadership had a lot of difficulty motivating the employees in regards to what they want to achieve, because it's a pretty difficult job, because you're going into, areas and things and populations that are, so any strategies on that? How do you manage the folks that work with you in the
Sure.
space?
So it goes back to what I said earlier of getting everybody to think of the framework of being a chief patient advocate for them and their loved ones. That's one job you don't want to suck at, right? You want to figure how am I going to make sure that my family and my loved ones have access to care. So what makes that challenging? If you show up to a doctor's appointment, or if you show up to a hospital, and they tell you that you're not network, or you have a copay, can we reduce those barriers? Can we help provide more detail? But we need to ask our employees, what is it that's challenging for them? What are they seeing? Get their perspective and help make them part of the solution. Because what generally happens is that outside groups will come and have internal focus groups without any of the boots on the ground people that are so close to where the problems are, and having their influence in helping to shape how they think is going to be the best. So you can guide them, give them examples of evidence-based practices, and tell them about, and really focus on level setting. What's practical? What's realistic versus, having these, ideologies that are not, business friendly or long-term accountability. Where I tell people, especially because I teach a lot to different healthcare professionals, it's okay to make money, but it's figuring out what's the return on investment for your activity. How do I help create value in terms of the business standpoint, but also generate value for my community? And there's ways to do that, but we can't just be so adamant about everything should be free. No one should have to pay for healthcare. That's not the reality of it, right? So we need to be true to ourselves and understand there is financial decisions that have to be made. Do researchers need to research every single thing? Absolutely not. We need to think about how does that research translate into reducing out-of-pocket costs for patients? How does it enhance care delivery? So there has to be a getting from the employer group employees, figuring out what's valuable to them, having them be part of the discussion, and then coming with shared values to create the solution versus me telling you what to do and then you not understanding it. That goes to the whole thing I said earlier about you need to explain the why, not just the what. The what is you need to do X amount of visits, you need to have X amount of patients because that drives revenue this way. But why? But that's not what our patients need. Well, don't worry about the why. Just do it. But is that employee seeing any direct benefit in their paycheck? Typically not, right? So we have to look at that reimbursement, that reward mechanism as to how do we reward employees that are engaged. Some are going to be super engaged, some are not. They're going to just punch in, punch out. That's fine. But we need to kind of figure out a way to help, reward the employees that are fully engaged. They're part of, solution-oriented actions versus those are just good at doing the delivery of the service.
Sam, you.
No, I was going to ask. No, if you have a follow-up, please go ahead.
No. Go ahead.
What I was going to ask is, if you can divulge that, right? You said 1,400 free clinics across the country, right? How do they get their funding? And is it being affected by all these cuts? Is it more governmental funding, private funding? That's a very... They play a very important role, like you said. 1,400 clinics serving populations across the country, and also with the new thrust on deportation and other things, they would be even scared if many of them are immigrants, or I'm just wondering, right?
It's a great question because these clinics have been, many clinics across the country have been around for decades. So having that long-standing community relationship where they are a safe place, people have trust in the work that they're doing. And most of the free clinics are funded by local foundations, local supporters. There's not a lot of federal funding that comes to the free clinics. There's, depending on the states, some state legislators will provide state funding for a free clinic, but that's not the case nationwide. Ideally, we've always advocated to get federal funding to cover the free clinics because they're providing such a valuable service to the uninsured. But that argument is not always heard. There are some things where there might be malpractice insurance coverage that we're able to be part of, but direct funding for services, we don't get federal funding for it. That's something that we've always advocated for and will continue to advocate for, because for every dollar invested in a free clinic, there's a clear ROI in terms of cost savings that helps the community and the state at a whole. Having less people show up at the ER because of them getting their medical care at a free clinic is pretty powerful, and that data is already out there. But it's just a matter of how do we look at putting the impact where it needs to be, where we like to always focus on teaching people healthy habits of, if they're uninsured, the goal is to get them insured, but teach them how to understand the healthcare system works, right? When you get into Medicaid or to commercial insurance, knowing when and where to use your card, how to have a conversation, because once again, we're trying to teach those healthy habits of elevating them so we can go back and help more uninsured people. There's never a shortage of uninsured people to help. It's just our ability to help them and the capacity that we have. And that really depends on funding. But it's mostly foundations, local funders, individual donors. And then some states, as I mentioned, will have state funding from the state legislature, state budgets that gets allocated to them.
So the good news is that all these cuts that is going on with the federal government is not going to necessarily impact you in a substantially big way.
Yeah, not the free clinics. There are other community organizations that focus on housing, food assistance. Those are impacted because they historically have gotten federal funding. But for us in the free clinic world, it's not that. It's all the chaos that's happening is going to make it a little uncomfortable. From a funding standpoint, it's not going to be as dramatic as others because we've always had to survive, because we've kept advocating to get federal funding and we never received it. We had to get creative. That's why I say we're incubators of innovation. We have to focus on how to survive every day. So every day we wake up thinking about, how am I funding my organization? How am I keeping my talented staff employed? How do I continue my mission and keep growing the community that we're helping over a period of time? So for us in the free clinic world, the uninsured world, we've always had to survive. Survival is part of our DNA, and it's that creativity of leveraging, how do I use technology to minimize operational costs, enhance the delivery of services? How do I leverage contracts and have conversations? And those are skill sets that aren't often taught in schools. It's more of things that you learn over time, but you have to be given an opportunity to learn. And that's really where volunteerism plays a big role. I always encourage people to go volunteer at a nonprofit. Learn how the system works so that way you could understand how to better influence in your regular day-to-day activities, how to be a better champion for those that you're trying to serve.
That's quite interesting. So you remember when years ago when we were providing, we are still providing software, you were saying that most of the free clinics were using Practice Fusion or the free EMR systems. And since it was, purchased by another entity, are they still paying for all these things, or is it?
So some are. So there's Athena Health, which is being used by a lot of clinics. There's a few other platforms that are now available, but they're scaled back. It's not the full. There is the. I like to give the Toyota and Lexus analogy, where Toyota does what it needs to do, and then Lexus gives you that comfortability, that luxury. There are a lot of luxury EMR systems that will give you all the stuff, but a premium price. But then most clinics need their Toyota experience. But then that Toyota experience is not necessarily the right experience. You're getting the base model where it doesn't even have like power windows or power doors, and they need a few extra added things to make it work for them. So clinics struggle in terms of knowing which technology platforms to go to, how to vet them, because when they call asking for help, the companies will try to sell them on like the higher end solution, and if you don't know what to look for, it's really frustrating because you have to figure out, how does it fit into my budget? This is what I have for a budget. What can I do with it? And then you kind of get stuck with some other solutions that may not be optimal for what you need. Some hospital systems will donate their EMR solutions to the clinics, just so that way it allows better communication and integration of care collaboration. But Practice Fusion is still used by a lot of clinics. Athena Health is probably now the most utilized, because there's a version that's given to free clinics that has the basic functionality that they need, but there still needs to be some enhancements that will allow them to run reports. For them to do value-based care, the current models that are given for free or scaled back are not going to allow them to. If you pay for it, of course, you can do all that work.
So one of the most important things with value-based care is the preventative care, which is quarterback through primary care providers. And this 14, if it was a very wise health department, they would understand the value that is being provided by these free clinics, because it is the first line of defense. They know these people better. They can navigate the patients better. Like you said, you're providing that everything that is required for a value-based care in terms of the patient navigation, the patient literacy, the patient education, patient support, and aftercare support as well. And I think, in his speech in the Senate for the confirmation, RFK Jr. was saying the importance of value-based care. He, in fact, said those words. He said preventative care is going to be the policy which they are going to follow. And if that is true, then I would think that they would see the value of all these free clinics and provide federal funding for those, rather than provide money or pour money into a problem that has already happened, right? And that's I really hope that's going to happen. Do you think they're going to do that?
Um, it's a great question. The hope is there, but we hear people make statements and broad statements all the time. So I always, I'm of the frame of mind that let your action speak for itself, where you can talk about it, but it's until your actions show that you really want to do it, then that's going to, tell us the reality of stuff. Where prevention costs a lot of money to implement, and that return on investment, as to what Shahzad said earlier, you don't see it right away. So are they going to have the patience to allow the investments to kind of flourish over time? How are we doing this? Some of the efforts by Robert Kennedy Jr. that wants to focus on removing additives for food, those things are going to be great ideas that everybody can rally around. But how long will it take to implement versus, going to courts and appealing and then reappealing, going to Supreme Court, versus the consumers are still exposed to stuff, right? So I think it really boils down to timing. How much time are they going to allow to create initiatives or invest in groups that show the value that could be generated? Their free clinics, the uninsured free clinic patients seen at the free clinics, I call them the invisible people, because the data that's collected on those individuals are not shared with anybody else. Typically, claims data is based on insurance adjudication claims, and then actuarials will make risk assessments, and then that's how you price out all your costs. But for all of us, all the 1,400 clinics that are part of the National Association of Free and Tribal Clinics, we have all this information. I can tell you who's the sickest of sick in your zip code that's potential for kidney failure, right? But it's a matter of, well, how am I making money? Because you're not billing an insurance, so I can't get claim adjudication. Like, the whole point is for us to proactively engage, and we want to share the data, but that's not part of the data sets. When you look at data warehousing and creating risk stratification, the free clinics have all this information. We can really create targeted approaches to care, but it's a matter of who's willing to support our efforts in doing it. When I've talked to large groups about, we have all this data that's sitting in a gold mine, data, they always say data is the new oil. We know there's value. Now it's just a matter of how much value can be generated so it can sustain us as nonprofits, because we do have to think like a business. We do need to think of how are we not passing cost off to the uninsured, to the patients that are financially struggling. How do we create other opportunities to sustain our organizations in our operations?
So one question: how is the collaboration between federally funded organizations like an FQHC or community health centers or the PCMH or CCPHCs? How does that link with the free clinics?
So it's a great question. There are not enough federal qualified health centers across the country. So the perception that the federally qualified health centers can meet the demand of all the uninsured people is unrealistic. And sometimes there is a Hunger Games mentality as to, we're both going for funding. Who to fund? Well, we're the free clinics are one corner, the FQHCs is another corner, and comparing what services. What we have to acknowledge is the fact that no one entity can do it alone, right? There is an overabundance of people that need care. How do we help funnel people that are truly sick in need of care to go to the FQHCs, have more specialists? To what Shameem was saying earlier about, leveraging existing resources and saving those that are limited to the more like intense patients that we need. So I think there has to be more collaboration between the federally qualified health centers and free clinics, where it is not a competition to say who's taking care of which individual. It's more of how do we help people as effectively as possible, but having that honest conversation. And this is kind of where now federally qualified health centers are getting a lot of funding from the federal government. All that funding is at risk. So now they're at the table asking, okay, how do we collaborate more? So to what I said earlier, the opportunity for all this chaos is the forced collaboration, where people have to put aside their siloed thinking and now think about survival. We've been surviving as free clinics across the country, and we will continue to survive because we find ways to make things happen. But other entities that have not been willing partners in the past have to become willing partners because they have no other choice. Where before you can say like, yeah, that's nice to know you, but I don't really need to, like, you're not really going to do much for me. But the need is there where federally qualified health centers, there definitely needs to be a lot more of them. There's a handful of lookalike FQHCs out there. There's been a lot of HRSA funding. But the need is, you could build more FQHCs, but does the community trust you? Where if you have a free clinic that has been in that community, that has that trust, why not work with them more closely to enhance your opportunity versus trying to build your own and then look at, can I get more federal funding? Can I get more funding from this source? Extending resources, in a meaningful way is important.
I'm reminded of that saying in our language: what is born in fire will not wither under the sun. You guys are used to working in harsh conditions, and suddenly, you never had funding, so nothing is going to hurt you at this stage. But Shahzad, anything?
No, I mean, I just wanted to say that, I think the biggest challenge in the delivery model is building trust. And the model that the free clinics have, that is a given or you won't survive, because there's no other, if you go to any other organization, there is some business model behind it. But for a free clinic, they're there to serve. So I think, that's a great point that Donney brought in, because you already have an arm that has already achieved empathy and trust, which is the most impossible and difficult thing to achieve in a community. So why not leverage and extend it? Because the FQHCs or all these federally qualified organizations are exactly trying to do the same model in a different way, although they're getting funding from the government.
And they're saying a mixed payer mix, right? They see commercially insured patients, they see Medicare patients, Medicaid patients, and then they have to see uninsured patients, right? So they're trying to balance out how do they see everybody to keep them sustainable, because the federal funding alone is not going to keep the federally qualified health center open. And I have to say, federally qualified health centers, I've worked in them. They are really good. They do really good job. It's a matter of knowing, don't try to take everything on yourself. Really know how to work with other groups, like the free clinics and other entities, to really spread, the capacity building, so that way the community truly benefits. It's not just more of, I'm looking at what my numbers are for the end of the year and am I hitting these financial goals. Free clinics, we do have limitations in terms of, not having full-time staff, a lot of volunteers being engaged. There's not a lot of standardization across the board, but we are trying to change that and driving the value-based care work. We have a project called the Roadmap to Health Equity. And that project is really looking at quality improvement in cardiovascular disease within the free clinic world for uninsured patients. So there is the capacity for us to do more, but it's giving us the opportunity and the funding where we can pay for the talented staff, because the staff and volunteers that work at free clinics are some of the best human beings you'll ever find. But we need to have funding to allow us to continue to keep them and to keep growing our work over time. But we need, we're all about collaboration. It's just a matter of, is everybody else up for the challenge?
It just hit me, right? Value-based care initiative started because the expenditure went out of hand. There was no logic on the spending, and obviously, I don't want to mansplain it anyway. And that, so the free clinics don't have funding. They don't have the expenditure, so they're already value-based care organizations, right? So maybe the federal government and other entities should learn a lot from the free clinics and how they are utilizing this whole perspective. Because on value-based care, it is a certain amount allocated per patient or per chronic condition per month, and you have to make sure you get the best outcomes out of it. So it's all about managing the money. So the free clinics are nowhere in that situation where they have to manage, too much money at that particular stage. But I think unless you have some more points to make, Donnie, is there any area that we need to discuss? I can close with a story.
No, I think it's been a great discussion, talking with both of you about the work of the free clinics and kind of the opportunities for collaboration. Free clinics come in all different shapes and sizes, where they're multi-million-dollar budgets and some are, less than $100,000 budgets. So there are many good people across the country here in the U.S. working to serve, and they work in rural, urban, and metropolitan areas. So it's not just one setting. And I think that's important when you look at value-based care. When you have medical deserts, pharmacy deserts, there needs to be a way to figure out how to leverage resources. So if there is a free clinic, can we work with the free clinic to enhance their capacity in a medical desert or a pharmacy desert? It's not just, looking at, well, this is only works in an urban setting versus a metropolitan setting, that rural settings don't apply. So what you said to earlier in terms of like in India and rural places that don't have a lot of resources, we kind of work in those same type of capacities here, where there's very impoverished people in impoverished regions here in the United States that we need to serve and do a lot more for.
All right. And do you think there is enough awareness about these free clinics and the work it does among the public?
Not enough. We try to, each organization tries to raise their level of awareness locally. The National Association of Free Clinics does a media campaign trying to raise awareness, but we don't have multi-million-dollar budgets to go and do a wide media blitz to tell everybody about who we are. So compared to like other nonprofit organizations that have a lot more money than us, the money that we have, we've spent on patient care, putting it back into serving the community. We're not going to have, $1 million to go in an ad campaign. If somebody wants to give us, if Melinda Gates or Mackenzie Scott wants to donate a lot of money to us, that'd be great, because then we can figure out how to increase the awareness of free clinics, but also sustain our core services to the public.
Okay. That is great. And I hope they'll hear this and they probably will listen to our video log, your vlog, as they say. But what I wanted to say about the impact of patient engagement and the right application of value-based care was this. I can't remember the name of the health system. They saved about $100 million by implementing effective value-based care principles, right? And that is from where you can understand everything that we do in terms of high engagement or high impact patient engagement solutions. So they did preventive outreach to patients. So they had a similar set of population in two groups. One, they implemented value-based care, 30,000 in each, and the savings they made was $100 million. So on the side where they saved the $100 million was around how they outreach the patient and remote patient monitoring and then patient navigation and the support. It was not just an app and say, okay, you can contact your doctor tomorrow. It was a combination of digital tools and, like you said, actual patient interaction, and then also marking care deviation and the payment models in which the doctors were compensated. So there is a whole bunch of things that you got to do to have effective value-based care. But whenever I hear this conversation from people, they are just, when they talk about patient engagement or patient literacy, it's all about, okay, I have an app for that, right? And I think that is one of the messages that we want to go out there and give to major health systems or organizations, where it is a lot of things that has to come together, and we call it high impact patient engagement pieces. But for today, this was a very great conversation, especially I wasn't aware that there were 1,400 free clinics, honestly. There's almost as many as the FQHCs. There are about 1,500 FQHCs across the country. So this is as big as the FQHCs out there, and the kind of work that you're doing has been great. We are happy that we were able to help at one point, but thank you very much for coming today. Any closing words from both of you? Please go ahead. Shahzad, you go first.
No, I think I'm good. I think um, it's really exciting to see how you are having a delivery model, already financially efficient and getting results, right? I know it's very easy to say it in one word, but I'm sure the challenges and everything that has been there. I think it's great to see that there are so many of them, and how they're actually doing this much longer than when people were talking about value-based care and outcomes and all that stuff. So that's really eye-opening and wonderful to know.
Thank you. Donnie, you will have the last word.
Yeah, I would say, I appreciate the invitation to speak with you both today. And I have to give you guys credit as a company to have the foresight, the willingness to kind of engage groups like Novascripts and me to kind of be willing partners. Because when we talk to a lot of, tech companies, there are not many people that want to support the work that we do. And, many, many years ago, you guys were open to my ideas of collaboration and helping us out in terms of how to really help serve the community. And, I once again have to thank you guys for having that visionary outlook of looking and thinking differently ahead of the curve, of being willing to work with small groups. We all come in different shapes and sizes as organizations, but the willingness to work with a small nonprofit like ours has been so amazing and life-changing because it allows us to grow our impact. So kudos to you guys for having that foresight, and I hope more people follow in your footsteps of being open to the conversation and not just looking at what's the profit case, what's the how much revenue can I make from this opportunity. I think you guys have looked and valued the human impact, which is what's the most important for us. So I appreciate and very grateful for our partnership.
It was our pleasure. Thank you very much. And folks, this concludes our episode here. Thank you all. Have a good day.